This is Kay Tillow. I am with Kentuckians for Single Payer Healthcare, and you're listening to Single Payer Radio. It's a program that we bring to you 3 times a week. The normal people who do this are Dr. Mike Flynn and Dr. Eugene Shively and Paul Hoppy. But today you have me and Harriette Seiler, who is the secretary of our organization and a very hard worker for many decades in this cause and this effort to bring an improved Medicare for all, to free our healthcare system from the profiting companies that dominate it, that cause such denial of care and such great costs to our country and to individuals. Our program airs on Monday, Tuesday, and Wednesday, and you can get in touch with our organization at kyhealthcare.org. There you can find information about our activities, and there's contact information so you can email us or call us. We'd love to have you participate with the work that we do. We need more of us to make the improved Medicare for all happen in our country. I'm introducing Harriette today. She has prepared a program, a discussion for you that we think will be of interest. Harriette Seiler.
Oh, thank you, Kay. It's a real pleasure to be with you. I'm originally Canadian, but I've been a member of Kentuckians for Single Payer since 2004. As I said, I'm originally Canadian, so I know single payer works. The Canadians share our need for more doctors, but everyone is covered and no bill ever arrives in the mail. Okay, I'm particularly glad that our organization, Kentuckians for Single Payer, KSPH, has been actively exposing the problems with the private for-profit insurers, which of course they don't have in Canada, and especially those who sell Medicare Advantage plans. Just this week, there have been news articles and posts in social media about Medicare Advantage denial of care. A group of healthcare advocates led by Dr. Carol Paris, a former president of PNHP, actually confronted the CEO of United Healthcare, who was testifying before the Senate Finance Committee. Congress really does need to pay attention to what's going on. Patients are being denied care. And even just this past week, on April 29th of 2024, ProPublica reported that a physician employed by Cigna, Dr. Debbie Day, she was employed to evaluate patient claims. You know, you've heard about prior authorization. A lot of people have to get prior authorization from their insurer in order to get care. Well, Dr. Day said she was pressured to review claims more quickly and to deny, with an aim to deny, a higher percentage. Kay, you will recall a similar situation when Louisville physician Dr. Linda Pino testified against Humana.
Yes, Harriet, I remember very well. Dr. Linda Pino had been a reviewer for Humana. She had been responsible for looking at the cases that came before them where a physician and a patient were applying for permission to do a certain procedure. And she testified that the company, Humana, had a quota for the doctors to deny, and that their pay and their jobs were dependent upon the denial of a number of cases. And she testified about that before the Congress. And as a result, she sacrificed a lot to be able to bring that truth to us. And there was even a movie made about it that is called Damaged Care, starring Laura Dern, and that is still available. You can find that on the internet.
Right. Well, and of course, I mean, that's a very sad story, and things don't seem to have gotten a lot better. Here in Kentucky, we follow news about Humana because our state retirees are covered by Humana Medicare Advantage. And there was recently a dispute. Now, many people in Louisville have doctors who are with Baptist Healthcare. I personally have doctors with the Baptist group. Well, apparently, Humana and Baptist had a dispute where each wanted the other, I believe the patients insured by the other or using, covered by the other, to use in-network doctors. And so people were scrambling. They thought, I've got a Baptist doctor. Do I have to have a Humana doctor to have a doctor? Because if your doctor's not in network, explain that, Kay. What happens if your doctor is not in network?
Well, it's unclear, but it's pretty much guaranteed that either you will pay more, or it may be that the insurance will not pay at all if the doctor is not approved. I know the companies dispute that, but they have made arrangements and have contracts with a network of doctors and hospitals and institutions. And that's really a big part of the problem, is that people are not free actually to choose physicians and institutions that best meet their need.
But if we had single payer, you'd have free choice of doctor, no matter where across the country. Isn't that right?
Absolutely,
Okay.
absolutely. People would be able to choose their physicians and their hospitals, et cetera. And you know, one of the big problems is that for Medicare Advantage, Humanas and others, the really best institutions, there are no contracts, and it's very hard to get to places like Mayo Clinic or MD Anderson or Sloan Kettering. The best cancer centers are not on the list of networks.
They're not on the list of networks. And I've also heard that Medicare Advantage often restricts where you can go for rehab if you need rehab.
It's a big problem. One of the physicians that works with our group dealt mostly with geriatric patients, and he said he could not find rehab centers that were in their listed networks for the Medicare Advantage people that were decent, where he could get good care for his patients. And on top of that, they often, Medicare Advantage, once you get into rehab, will then say, okay, we're going to reevaluate whether you need more time. And we had
You mean more days?
more days in the rehab center. And we had someone who was a state employee who called us and said that he was in a rehab center recovering from a big surgery. And he was told that even though he could not yet put weight on his leg, he was told that were no longer going to authorize it, that he had to go home. They weren't going to pay for his rehab.
Well, and is that also where one of the Medicare Advantage groups, and I'm not sure which one, went to AI and was using some kind of formula to decide who could have a certain number of days in rehab or not? I'm not sure which.
You are correct. I don't know which one it was, but I think that's the direction that they're going, is that they increase the profits by denying care or delaying it
Or
and
cutting back.
so that people don't get as much care. They don't have to spend as much, and that means that they get to keep more of the money that is our public money. It's Medicare money from the Medicare Trust Fund.
Right, well, I've heard of this new book called The Plunderers, who take money from Medicare. That kind of reminds me of something I didn't understand, and that's capitation. That's where Medicare gives the insurer a certain amount of money for each patient. And the Medicare Advantage insurers, if they deny care, they pocket that money.
Absolutely. That's how it works.
Well, I don't know. I'm not slick enough, I guess, for that. All right. Now, I've said that here in Kentucky, we follow the news about Medicare, about Humana, excuse me. And in Louisville, we especially follow the news about Humana every time they make a move, or they have a new executive, or they make another billion in profit. It's in our local papers because Humana is a corporation that has had its headquarters right down on Main Street in Louisville. A big building built of Carrara marble from Italy with real gold strips down the front. And of course, our organization has often demonstrated, I hate to say against Humana. Well, no, I don't hate to say it. Against Humana, we've demonstrated in front of that building. And actually, Beckers, who writes about business, has said that Humana in Louisville has approximately an estimated 10,000 employees in the Louisville area. I find that almost hard to believe, but I know they have a lot of employees. Everywhere you go, in every book club, in every group, some mother's son or daughter works for Humana. I'd like to kind of go on about the fact that there is a book has recently been published about the life and the business career of David A. Jones, Sr., the founder of Humana. And of course, he was newsworthy because he was a philanthropist and a business leader. And people just assume that he must really know business, etc. And he's been honored recently in Louisville by a huge mural, or they could call it a big hanging wall poster on the downtown YMCA building. And a statue of David Jones by the esteemed sculptor Ed Hamilton was recently unveiled at the company's waterside. It's down, I wondered where it was. It's not in front of the Main Street building. It's down at the company's waterside location or building. Well, anyway, a friend called my attention to the book, the title of the book is Always Moving Forward, a memoir of friends, family, and building Humana. And it was written in conjunction or based on interviews with Bob Hill. And it was published posthumously in 2023. My friend recommended that I look at the appendix of the book on pages 385, 389. I mean, it's really just 4 pages. And in which Jones offers what he calls some thoughts on healthcare system reform. So he suggests some reforms, some of which he believes his company is already doing. However, one of the things that he talks about is that he favors universal care. And my friend said, well, how is that different from single payer? And I sort of said, oh, all the insurers want universal care, but they want to handle it. They want to sell it. And of course, they want us all covered by them. And by them, I mean all healthcare insurers who are, let's not forget that they are seeking, above all, profit. I was especially interested because David Jones grew up in a low-income family. Apparently, his mother worked very hard, and like a lot of people today who are uninsured, usually they are working people. However, or there's at least one member of the family working, but they don't have insurance. Well, of course, this was prior to the Second World War when David Jones was growing up, and until, he eventually went to college, probably on the GI Bill. But I couldn't understand why someone who grew up in a low-income family would think it was all right that people who can't afford insurance don't get it, and if you don't have insurance, you don't have access to care. I just couldn't believe that he wouldn't want everyone covered in some way that didn't involve ability to pay. Kay, you know so much about the issues and problems with the private healthcare insurance industry. I thought we might go over some of his recommendations. The first of which was this call for universal care, which we agree with. We want universal care. And he said that he wanted universal care and that it would render moot, I never can say that word right, pre-existing conditions. So he wants everybody covered, and he thinks if everybody's covered, there should be no concern about pre-existing conditions. And this was written in 2018, and I'm surprised because we already know the ACA said you need to be insured even if you needed to be able, correct me.
Well, you're right, Harriet. It said you need to, that the companies can't discriminate against you because of a pre-existing condition. In the exchanges that were set up by the ACA, of course, that didn't fix it in a lot of other places because we now have those short-term programs that have been set up. And in those, they certainly can discriminate against you for pre-existing conditions. And within Medicare, if you don't buy a Medigap plan immediately, like if you go into Medicare Advantage, then you later decide you want to go back to traditional Medicare, you are no longer protected against charging you great sums or even denying you a Medigap plan. That's the supplementary plan. So, and in many other ways, they were still able to discriminate about pre-existing conditions because companies are able to put different drugs on different tiers.
Oh, that's right, where they can, where you'll find that your drug that you need is not in there's a special word, I'll think
right. of it. So what happened was that, for instance, the drugs for, say, people who have MS are very expensive. And so those drugs would be on a tier where you have a very high copay, and therefore it acts as the same thing to exclude people from purchasing that plan, and it keeps out the expensive patients, which they're always seeking to do.
Well, thank you for that, because it's hard to understand all those fine points. But in the end, it's either the beneficiary, the patient, who gets shafted. Can I say shafted? I hope so. Okay, now I do notice on in the very first page of the appendix 385, he does explain how health care is currently paid for, and we have Medicare and Medicaid, and then he talks about the non-elderly. I always forget to differentiate, but the non-elderly are the people who aren't seniors, or and the near, he says, are non-elderly near poor are provided for by hidden subsidies. And I mean, he doesn't really say what those subsidies are. It's government, and he's very against. He wants to use government through Medicare and Medicaid, but he says whenever the government provides subsidies, the costs are shifted to the taxpayer, and he says to the worker, and the private. He says when people are covered by the taxes or the government, well, perhaps we can look at this appendix. Now, on the first page, he outlines how healthcare is paid for in our country right now. Of course, for seniors, we have Medicare, and for the low income, we have Medicaid, and he refers to hidden subsidies, but I believe he means whenever the government comes in to help provide coverage for our non-elderly near poor. And he may also be talking about those people who fall into the gap. They make a little too much to qualify for Medicaid, but they don't have enough money to buy a private plan. And so there they are, left uninsured. Okay, I think maybe we should go to Jones's proposals for reform. He does still think we need reforms, and he's outlined 10 proposals or points. And so let's see if we can't quickly go through them.
Okay.
All right. Number one, he says increase competition. Well, of course, that is what all capitalist insurers want. They're always talking about increasing competition, and they're talking about the market. And I remember Joseph Stiglitz, the Nobel economist who won a prize for his research showing that the market doesn't work in healthcare. People can't pick and choose if they're in the midst of a heart attack. They can't choose what they think is the least expensive place. They have to get treated right away. Let's see. So increase competition and lowering costs. Oh, he thinks that. The one thing he does say is that he thinks employers and individuals, small employers, should be allowed to purchase insurance across state lines. Well, I agree with that. If we had national single payer, you could go across state lines.
But you wouldn't be purchasing anything.
No.
You would be automatically covered.
Right.
You know, it's funny to say that, because the way an insurance executive thinks is the way he says this. I mean, the health insurance is regulated by the states. So if he can get out from under the state regulation, they can make even more profit if they go across the state line. So it's not going to help the people. You know, we pay, in this country, we spend double per capita what they do in other countries.
In other advanced countries.
Where they have, you know, universal care, either single payer or national health service. So we're spending more and getting less. And
that's right. Well, and I mean, those countries also regulate so that you don't allow profiteering to go on.
Right. It's the profits that are at the center of the problems that with our people getting care.
Now, item number 3, he suggests that it should be portable across state lines or from job to job, etc. But we all know right now, we've all heard of COBRA, and he thinks COBRA is, that COBRA allows individuals to maintain with their ex-employer an affordable level of insurance, such as a high deductible plan when they leave a job, as long as they pay the full amount. Sorry, I think I banged the desk at that point. But we all know how awful COBRA is. You've just lost your job, and if you want to be covered, you have to pay a premium to COBRA.
Right, you have to pay the entire amount at a point at which you don't have an income,
Yeah.
which is impossible because employers' employment-based insurance is something like $22,000 a year now.
Oh my gosh.
So if you have to pick up what the employer was paying for you, it's totally unaffordable, and people can't do it.
All right, now the next thing, number 4, so we wouldn't agree with his number 3 about, we believe in portability. Of course, in Canada, you can go from job to job. You can go from being an artist to being an executive, or from being an executive to being a painter, and you're covered, and your family's covered, and you don't have to worry about that. In number 4, he thinks you should allow paid buy-in at local insurance rates to Medicare or Medicaid for consumers who are denied coverage because of pre-existing conditions. And I don't understand this, because he's already said pre-existing conditions wouldn't be a problem. But I mean, he thinks that we should be allowing people to kind of buy into his kind of Medicare, I guess. I find that a rather odd recommendation on his part. Do you think
It's strange indeed that he's assuming that the insurance companies are still going to be able to deny care for pre-existing conditions, which basically they are able to do by selection of who they cover, where they advertise, who they want to pick up.
For example, with Medicare Advantage, I think they've moved out of some counties in certain low-income parts of the country.
Mm-hmm. The insurance companies were notorious for setting up walk-up offices where seniors had to apply to get Medicare Advantage, so no one who couldn't do the steps would be able to apply for the insurance, which is a beautiful way for them to select the healthier people, which they managed to do.
You would call that sneaky silver sneakers.
Yeah, you could call it that.
All right. Now, he believes in tort reform. He says, this is item number 5, lawsuit or tort reform, because the fear of litigation leads to defensive medicine, legitimizing expensive, unneeded tests and services. Now, we've been at lots of conferences where they talk about too much care. And I've heard you say, why don't you say it now? Our problem is not too much care in this country, it's
too little care. Too many people who aren't getting the care that they need.
Right. So now in Canada, there isn't so much money tied up in litigation, because I'm sure I'm not going to get this right, but suppose it had to do with an employer or something. They wouldn't, or some kind of hospital malfeasance of some kind. In Canada, they don't have to pay so much because they don't have to pay for future medical bills. Is that right? I don't think I have that right.
No, that's perfect, Harriette. there wouldn't be, with a single payer system, so much money needed to cover future medical expenses, because that's covered. Everybody's covered for their medical automatically.
Right. In fact, don't we say for all medically necessary care?
Right.
Right. So if you had been injured in a hospital or at a doctor's office or something, you would be covered, completely covered. Now he does talk in item number 6. He says they should all, by a date certain, perhaps in 5 years, connect electronically and use standard forms. Well, we believe in that. We want a single payer to be like the VA, where everybody's using the same electronic system, and and if you go to another VA veterans hospital, they can immediately pull up your record, etc. However, he says that will aid transparency and provide robust real-time medical information. And and I'll talk about this in a minute, but he says allow consumers to assume greater personal responsibility. In fact, he's assuming the patients are going to be looking at these medical internet records, and that they're going to be able to pick and choose either a procedure or a hospital because of that. Now, you and I talked about this at one point, and you said the problem right now is we've got medical records in different hospitals, but they're all owned by
private companies, and therefore it's not a unified system of medical records. And the biggest problem with it is that it's geared around billing, because our whole system, is requiring your physician's not looking at you when she or he is seeing you, because they are forced to
look at the computer.
And to enter all of the things that will make it possible for them to do the billing. If our system were not based on billing and all of this competition and differing prices, etc., it would not be so complicated. We could have an electronic system that worked just designed around care,
right,
that would enable physicians and patients to see what they needed to do in terms of care, not in terms of making money.
Right. And wait a minute, that brings up the issue of coding. Is that what you're talking about? Like where the nurse has to put the codes in and the doctor has to put the codes in of what was done to the patient? And then they start talking about they upcode, the insurers upcode so that they can ask Medicare for more money.
Absolutely, because Medicare Advantage, those private, unscrupulous programs, can upcode, in other words, to assert that the patient is sicker than they actually are in order to up the amount of money that
they take from the
Medicare pays. And it can go up from $1,000 a month to $3,000 a month based on upcoding, and all of that is really fraudulent. And
well, haven't there been some court cases about that? I'm not sure about Humana, where they've actually, what did I just read? That CMS has barely given a little tap on the wrist to some of these Medicare Advantage insurers who have been upcoding.
All of these companies have been fined for doing things that they weren't supposed to, but the fines don't stop them. It's just kind of a part of doing business, because the money is minor in comparison to how lucrative it is to be in this business. There is recently an effort by a number of people around the country to expose the fraud in Medicare Advantage, to expose the denials and the overpayments. And we have MedPAC, which is a government body, Medicare Payment Advisory
Oh, I've
Committee,
seen that.
that has reported that over 80 billion annually is overpaid to the Medicare Advantage companies, which is just huge. And Physicians for a National Health Program says they believe it's even greater. They think it may be as high as 140 billion annually. You know, a billion here, that gets to be
Big money pretty soon, right?
right.
Right. Okay, now number 7, tax reform. And I remember when I first looked at this, I said, ask Kay, because it has to do with when you pay for things with either pre-tax income or after tax. And he says there's this, he keeps talking about this tax subsidy, and that there's this incredible amount of money this subsidy that should be phased out and increase instead of public money. I think he says he wants the consumer to pay more, and of course he's this. In fact, I wanted to call this program "Skin in the Game" because this is when he first starts talking about making consumers pay more, and in order, and I'm not sure I understand this. Can you, it has to do with employers, and I know employers get a tax break when they provide
Right.
employer.
They don't pay taxes on the money that they use to purchase the health care
For their
for the
employees.
employees. So it's like, you know, if they pay the worker wages, that's taxed for them and for the worker. But the health care benefit is not. So it's a huge amount of money that the government forgoes by allowing employers to be tax-free to purchase this health care. Of course, with a single payer system, we could do it differently. We could have it paid for by taxes, and we would get it away from employer control, which would be a huge help to workers.
Right. Well, and now I know in Canada, you know, everybody pays a little bit through their taxes, but I mean, they actually get something for their taxes. Now, he keeps referring to monies that come from the government as being subsidies, I guess. And a minute ago, you said something about, talk about subsidies, it's those insurers that are getting.
They're getting the subsidies in the Affordable Care Act, you know.
Right.
It was set up, well, people can't afford how much the insurance costs. So the Affordable Care Act set up that there would be government subsidies to help people to purchase it. So we're getting subsidies, the person never sees it, it goes directly to the insurance company.
Right, so if you want to buy like a silver plan for the ACA and you can't afford it, the government will give subsidies to you, but as you say, it goes all the way to
you don't see it. You don't see it at all. It goes into the insurance company pocket.
Well, and there's still a deductible.
And right, I think we should talk a little bit about that. You know, that's a part of too much of our healthcare system is geared around an insurance company ideology that says people are getting too much care, they're using it too much, doctors are sending it too much to get care, so we have to put barriers, make them pay deductibles,
right,
make them pay the copays, let's be sure that they're really sick and you really have to hit them hard with these. Well, that's a part of their effort to put barriers in the way of usage, because that doesn't do anything good for us. That blocks preventive care, that blocks, you know, decent care, and that's the biggest barrier for people.
People are paying for plans, and then they look at their deductible and they're feeling sick. They think, well, particularly in the month of January, they'll say, oh, well, I can't afford my deductible, I can't afford to go to the doctor.
And it's thousands and thousands and
Oh, I
thousands
know.
of dollars, Neil. So we really find that with the Affordable Care Act, while there were some gains made, what we have done is increase underinsurance. The number of people who nominally
They have a policy,
a policy, but they cannot afford to
they
use
can't
it.
use it,
And
right.
they don't go to the doctor, they don't go to the hospital, they deny themselves the care, can't afford their drugs. We have a cruel and inhumane and immoral system.
Well, when you talk about inhumane, I know you and I have talked about this before. And one time we were at some kind of big healthcare conference downtown, and whoever the guru of the day was talking about how we have to have patients and consumers or clients or beneficiaries have more skin in the game. And that horrible expression, you feel like you're scratching the skin off your arms, and they think that consumers have to be paying a little bit in. And I even do have friends who have said, well, everybody should pay a little bit. And I said, yeah, but what if you can't afford to pay a little bit? What if you've got to make your rent payment and your food payment and you've got a sick child? Well, of course, children maybe do get a little break on this, but you're feeling sick and they think it's okay for you to just stay home and not get treated because you didn't want to pay your little fair share. And I mean, it's a cruel expression. Where does it come from? Do you know, skin in the game?
Well, I think it may come, it may come from Shakespeare. It may be like a pound of flesh.
Oh my gosh, right.
But it's an ugly look at this because we need for people, we will all pay a little bit for our health care through our taxes, but when you need to go to the hospital, go to the doctor, you will not pay.
Right.
That's where we don't want the barriers to care when you need the help.
Right.
And that's what we will do. It will all be paid for in advance, and we will not pay what we're paying now because our system costs far too much.
Well, I think PNHP has now put out a calculator
I saw that.
where you could calculate how much money you would save if you.
Right, if you go to pnhp.org, that's Physicians for a National Health Program, you're going to be able to find a link to that calculator. It's by Jim Kahn, Kahn, and it's also at the Health Justice Monitor. And he has worked on it. I haven't used it yet, but he says that you can go into it and put in what you're spending now and figure out what you would pay that is less.
Right.
Would we have a national single-payer healthcare system?
Right. Well, and I mean, the Canadians, they had this, what was like a human rights conference, and I used to know the name of it, where people said, we will contribute to cover the cost of health care for our fellow Canadian citizens, our fellow Canadians. Okay, number 8, David Jones, talks about Medicare. He says it's soon going to be bankrupt and must be reformed. Well, I mean, I know that it wouldn't be bankrupt if they weren't taking so much money out of it and if they weren't profiting from it, the insurers. He thinks he would reform it for 5 years, current beneficiaries would be grandfathered in, but then baby boomers, he says, who are already familiar and largely satisfied with private insurance. I mean, who's satisfied with private insurance?
Nobody
is. So he says these baby boomers should be allowed to choose keep their current private insurers when they become Medicare eligible. And after 5 years, all new Medicare beneficiaries should be required to maintain or have a private plan. And then he said maybe we could give them each a voucher equal, and I don't really understand this, to perhaps 75% of the, and it's not their age, the voucher equal to perhaps 75% of a location-adjusted national average cost of traditional Medicare. So he's looking at the cost of traditional Medicare, and he's going to somehow, I really don't understand this. Do you,
Well, he
Kay?
wants it all privatized. I mean, basically, that's it. In this, he's saying he wants Medicare is going to be broke and he wants to phase it out. But in fact, they are phasing out traditional Medicare by taking over with the preponderance of these Medicare Advantage plans,
Yeah, that's a great.
which are privatized form.
Right, and he says, oh, they'd be able to acquire the plan that meets their own needs, etc., and pay any balance personally. Here we are with skin in the game again.
Right, you know, we have, our retirees in this country are not well provided for. We have many, many people on pensions that are inadequate and Social Security that is not adequate. And to think that we're going to have to pay 25% of the cost of our health care in our golden years is just ludicrous and cruel.
Right, well, and he says there should be some subsidies, but varying by income, to enable low-income seniors to purchase an average cost plan. We already talked about that. That's the kind of thing that would happens now in the ACA, where, and then he says, but each person should pay some portion of the premium. So we're back to skin in the game.
Skin in the game, right.
Again.
And he also says Medicare and Social Security eligibility age should rise as life expectancy rises.
Oh, well, isn't it true that our American, I just saw a Twitter or a tweet and it showed a graph that our life expectancy is going down.
It went way, way down. And it's really an indicator of something terribly wrong, particularly with our healthcare system. We are now 4 or 5 years behind, I would think, the average of the European and other systems.
It was close to 4 years on the chart I saw on Twitter.
I think we're at about 78 is the average life expectancy now. It used to be higher, and it's something like 85 in Japan, who happens to have a real universal healthcare system.
Okay, now, Kay, I don't want to kind of go on forever, but he even talks about Social Security, and we know that the reform to Social Security should not be to raise the age, but to raise what they call the cap, so the wealthy pay more.
Right. We have, well, they already raised the age of retirement in Social Security now to get full Social Security. It's beyond 65 years. But the idea of raising the age even more is just a terrible, terrible idea. We need to lower it, if anything, because we have many people who work jobs that are debilitating and cannot work, and we have people who don't have pensions and they have to work, you know, until they drop. And we need to provide for people to be able to retire without stress, without the stress of not knowing how to meet the next medical bill, how to pay the next rent.
Right.
We need to provide decency and dignity for everybody in our country.
Right. Well, okay, number 9 here is he's like our local Kentucky legislators or legislature this year, where they're trying to curtail the spending growth in Medicaid. And of course, and here he even says rapid unsustainable spending growth in Medicaid, disability, and other federally mandated programs is overwhelming state budgets. Well, now we see that some of these for-profit insurers are now meddling in Medicaid, including Humana. They
Right.
are now they've become a Medicaid MCO, a managed care
organization.
And all you have to do is look at what they pay their CEOs and what their earnings, their profits are. Didn't I just see something, and I'm not sure it was Kentucky, but I think it was KFF, the Kaiser Foundation, saying that even with the unwinding of Medicaid recently after the pandemic, where people are getting shunted off Medicaid, that these private insurers are making buckets of money, profits.
Oh, they are indeed. They have taken over Medicaid, and in almost all the states now, it's all turned over to the private insurance companies to take out their profit, and with huge CEO payments and huge profits off of the poorest of people. Medicaid.
I mean, they put in those work requirements. I suppose that's supposed to be skin in the game. I don't know, but it's just terrible. And then I wrote horrors in the margins here. He even thinks that federal appropriations for Medicaid or disability programs should be, how he can dump on the disabled, I don't know, should be converted to block grants. Horrors to think of our state legislators managing block grants.
To put the state in charge of deciding how the money should be spent.
Right. Okay. We're almost to the last reform. He does mention that Clinton agreed that Medicaid should be regulated, or what was it that Clinton put the work requirements in?
Well, he did it with the welfare system, who cut way back on
So
the
you
ability.
mean that's like
the ability
of food and everything?
The ability of people to go to school, say, and get a university education while collecting welfare in order to be able to get a really decent job. He cut way back on that ability, way back on welfare funds.
Yeah, I do remember a little bit about that. Okay, the last reform he goes back to universal coverage. Everybody has to be in it. And he said, the young and healthy may not like it, but as they age, they will wish to be included in the insured pool. And so again, he's talking about subsidies, and must be provided to those unable to purchase an average cost plan. So this is, but each payer should pay something. So he's talking again, he talks about that. That's recurring throughout his whole appendix. His whole plan for reform is to shunt it all off to the poor, to make the poor pay more, which they can't afford to pay, And even there should be this is very much like the ACA. Subsidies varying by income must be provided to those unable to purchase an average cost plan, but each person must pay something. So let's see. That's the end of his reforms. Oh, he's something here. Oh, and then he talks about, I mean, I do have friends who think that the solution to all our healthcare problems and costs is prevention. Well, you know, if you inherited a tendency for high blood pressure or something, or some kind of heart ailment, I mean, or a kidney ailment or something, all the wellness programs in the world or prevention programs aren't going to help. You're still going to need coverage.
Right, Harriet. I mean, we need a healthcare system. David Jones thinks that they should take in all the money and give it to Humana, and that no one should ever use the system. And if they ever go in the hospital, it's their own fault because they didn't take care of themselves properly,
Right.
which is the insurance company way of looking at the healthcare world.
Right. Well, and in his conclusion, he thinks that his suggested reforms are clear, simple, and built upon existing strengths. It's built upon the profiteers, it's what it's built on. And he kind of takes a pot shot at the ACA, saying they're more easy to understand than the Affordable Care Act. And so,
Well, clearly, we should not be listening to the insurance industry when we want to look at what kind of healthcare reform our country needs. So, because they have a totally different perspective on it as a basis for their profit, rather than something that is a humane and moral and decent society, providing what we know in medical expertise to all of the people within our country.
well, and also something that's working in other places.
Right. We know that healthcare reform in the form of single payer or in the form of a national health service works around the world, has brought care to everyone, produces better outcomes, produces greater longevity, produces a better society, a more humane way of using the country's resources, and it costs less.
That's right. I'm going to go out there and get that calculator, see how much I can save. Thank you, Kay. Thank you. I needed your help to provide answers.
You've been listening to Single Payer Radio from Kentuckians for Single Payer Healthcare. Thank you for listening.